Hello, I'm Namyoung Park in Kyung University Hospital at Gangdong and the first author of the study In-stent RFA with uncovered SAMs for tumor ingrowth or overgrowth in distal malignant biliary obstruction. Although both plastic stents and SAMs are frequently used to relieve malignant biliary obstruction, many studies have shown that the use of SAMs is associated with better stent patency and lower rate of complications. Based on these findings, many guidelines recommended the use of SAMS insertion for palliative drainage of malignant extrahepatic biliary obstruction. However, tumors continue to grow after biliary stenting, and that is leading to stent reobstruction. In addition, as new anti-cancer treatments showed improved survival outcomes, the problem of stent reobstruction has become more prominent. Therefore, local methods to prevent these problems have been required. Several previous studies have demonstrated the safety and effectiveness of endobiliary RFA. We considered this local regional therapy could improve the time to recurrent biliary obstruction or RBO and investigated the efficacy and safety of in-stent RFA. To analyze the exact effect of in-stent RFA, we enrolled the patient who received uncovered SAMs to treat the tumor in or overgrowth. The only difference between the two groups was whether or not RFA was performed. At the first time, we found the time to RBO was superior in the RFA group, but the difference was not statistically significant. However, because our study was performed retrospectively, some factors that could affect the time to RBO were not balanced between the two study groups. For example, more patients received chemotherapy after stent revision in the control group. To reduce the imbalance between the two groups, we performed propensity score matching, and we found a significantly improved time to RBO in the RFA group. The safety of in-stent RFA was also investigated. We checked all the adverse events in the RFA group. None of the 14 patients suffered from serious adverse events. The low complication rate may be attributed to some factors such as the temperature-controlled RFA system and RFA for distal malignant biliary obstruction. RFA session was interrupted in 5 of 14 patients. All of the RFA interruption cases were caused by in-stent contact, and the interruption could be overcome with repeating RFA in the same session in most patients. Temperature-controlled endobiliary RFA system is more recently introduced RFA method which can monitor the temperature at the ablation site to prevent tissue overheating. In addition, the RFA system we used provides 4 different lengths of RFA probe, and the shortest catheter length was 11 millimeters. The various lengths of RFA probe provide some practical advantages. We could choose the appropriate length of catheter to cover the whole structure area with as little overlap as possible. And the shortest RFA catheter was useful, especially in angulated lesion, because the angulation could interrupt the RFA session due to in-stent contact. In detail, with the 11 mm RFA catheter, in-stent RFA could be performed in stepwise manner. In conclusion, in-stent RFA followed by uncovered SAMs placement is safe and feasible and may improve the time to RBO as a stent revision for occlusion SAMs in pancreatobiliary cancer.